Hello everyone, good evening. I am Dr. Vyshnavi, your ENT faculty here at PrepLadder. Today we are going to discuss few MCQs from otology. Tomorrow we are going to do rhinology and a part of larynx and pharynx as a part of our discussion for the upcoming NEET PG 2023 examination. So today's MCQ discussion will be only concentrated on otology topics, on the topics of the ear, and then we will do the rest of the topics tomorrow, and if necessary we will do another session to compile all the topics together so that you're exam ready. So without waiting any further, let's begin with our first question. The first question says, which of the following is the single most important initial investigation in an adult presenting to you with unilateral serous otitis media with effusion? So the question is asking you that in an adult patient, which is the single most important investigation? So would you do a CT scan of the temporal bone, CT scan of the paranasal sinuses, immunoglobulin E, or flexible nasoendoscopy? So please let me know your answers in the chat box so that we can go ahead with the discussion. Hello everyone, good evening. Kunj, Shubham, Ram Bhaskar, Shreya, and so many more people who've mentioned hi. Very good evening to all of you. Okay, so I see a mixed response coming from all of you, and I see some of you say it is A, some of you say it is D, and some of you are mentioning it as B. So we are talking about an adult with serous otitis media. We're not talking about a child, and we're talking about unilateral serous otitis media and not bilateral serous otitis media. So whenever there is a unilateral SOM in an adult, the most common cause happens to be what? The most common cause happens to be nasopharyngeal carcinoma. But if the same question is asked for unilateral SOM in a juvenile age group, then your answer will change to juvenile nasopharyngeal angiofibroma. But here the question is asking to you about adults, so your answer is nasopharyngeal carcinoma. Now, how do we identify nasopharyngeal carcinoma and which is the best investigation? Of course, some of you may think it is the CT scan of the paranasal sinuses. Yes, I can tell that yes, on a CT scan of the nose and paranasal sinuses, you can identify a nasopharyngeal mass. But when the mass is really small, do you think you will be able to identify on a CT scan when it is a 1 mm growth or a 2 mm growth? You will not be able to appreciate those changes on CT when it is very early in the disease. But when the disease is extensive or it is a very big disease, then you will be able to identify the lesion on a CT scan. But the first investigation that you need to do is a nasal endoscopy. So when you pass a fiber optic nasal endoscopy from the nose to the nasopharynx, you will definitely be able to see the carcinoma as an abnormal looking area, and at the same time you can also take a biopsy and confirm if it is malignancy or not. So they're asking you which is the single most important investigation. So your answer will be flexible nasal endoscopy. So I hope you got the answer to this question. Yes, CT scan of the paranasal sinuses can be added as a complementary investigation. I'm not saying no, but you will have to do a nasal endoscopy to check the nasopharynx first to look for any abnormal area in the fossa of Rosenmuller, and if necessary, if it looks abnormal, you will have to take a biopsy. Okay, so in children, Kapil, the answer will be adenoid. So in children, there is bilateral SOM, and bilateral SOM in children, the most common cause is adenoid hypertrophy. So in adults with unilateral SOM, you're going to think about NPC, whereas in juvenile age group, JNA, and in children, you're going to think about adenoid hypertrophy. Okay, let's go to the second question. The temporal line in the Mac-Evans triangle is the surface landmark for which important structure? Is it the mastoid antrum? Is it the endolymphatic sac? Is it the sigmoid sinus? Or is it the dura of the middle cranial fossa? So again, I will wait for your answers in the chat box. Very good. I can see many of you are answering it, but not correctly. Many of you are answering it as A. Here I would like to emphasize a very important key word that has been given to you in the question. They have given you the temporal line in the Mac-Evans triangle. They are not asking you only Mac-Evans triangle. They are asking you temporal line in the Mac-Evans triangle. So what does the temporal line represent? So we'll do one thing, we'll quickly see a small animated video and then we'll come back to answer this question so that everyone will answer it for yourself. Okay, so let us see this video. So whenever we do a mastoidectomy, we need an important landmark to enter the antrum. So first what we do is a post-oral incision where we take an incision behind the pinna and elevate the skin and subcutaneous tissue. These are our landmarks. The supramastoid crest is a true landmark. The second line is drawn across the posterior canal wall and the third line is a tangent drawn to the first and second line. Now, if you drill in this area, you will identify the mastoid antrum. So, this triangle is your Mac-Evans triangle, which is a surface landmark for your mastoid antrum. But each line represents something. The tangential line that we drew initially is representing your sigmoid sinus. The supramastoid crest or the temporal line represents your tegmen, which is the which represents the dura of the middle cranial fossa, and the imaginary line across the posterior canal wall represents your facial nerve beneath it. So each line has an importance. So now that you know the importance of all the three lines and the structures they represent, go back to the question and answer this question. They're asking you temporal line. What does that temporal line or supramastoid crest represent? Now I want to see how many of you will answer. So supramastoid crest represents your tegmen. Okay, so tegmen is nothing but what? Above the tegmen you have what? The dura of middle cranial fossa. So you have the dura of middle cranial fossa. So the answer is D, dura of middle cranial fossa. If they would have given you the question instead of temporal line, they would have given you tangential line, then your answer would be sigmoid sinus. And if they would have given you just Mac-Evans triangle, not the temporal line, not the tangential line, not the line across the canal wall, then your answer will be mastoid antrum. So only Mac-Evans triangle, answer is antrum. If they ask you a specific component of the Mac-Evans triangle, then you have to be specific in your answer. And very good, all of you have answered this now absolutely right, and I'm sure that you're not going to make this mistake in your examination. So let's go to the next question. In that case, this is a very easy peasy question. Which organism is most common cause for acute otitis media? So this is something that keeps occurring often and it's a very simple question and I'm sure all of you know it. So just shoot the answers to me in the chat box while I'm waiting for all your answers. So this is something that you should know very easily because in ENT हर कोई infection यही organism से होता है. तो ये कौन सा organism है? Very good, all of you are absolutely right. It is Streptococcus pneumonia. So in acute otitis media or acute suppurative otitis media, the most common organism responsible for causing this is Streptococcus pneumonia. Okay, let's go to the next question. A little difficult, but again a common repeat. Gradinitis syndrome is characterized by which of the following? Otorrhea, ipsilateral abducent palsy, and pain in the trigeminal distribution, conductive hearing loss, trigeminal and vagal involvement, pyrexia, otolgia followed by otorrhea, deafness, vertigo and tinnitus. Now this is something that is to be known by everyone. What is Gradinitis syndrome? A common repeat that we see, and I'm seeing most of you are answering it absolutely right. For those who do not know, a quick explanation for Gradinitis syndrome is it is a complication that we see following petrositis. So what is petrositis? Let us understand. Now, if I remove the skull and if I see the base of skull from above, this is how it would look. So, we have the external auditory canal, the middle ear, and we have the petrous bone, which is a leaf-like bone. We have the inner ear in the petrous part of the temporal bone, and we have the internal auditory meatus. Here we have the brainstem with midbrain, pons and medulla. Now from pons we have 4 nerves. We have the 5th nerve and 6th nerve going anteriorly, and we have 7th nerve and 8th nerve going in the internal auditory meatus. So whenever there is inflammation of the petrous apex, what will we call it as? Petrositis. So what is petrositis? Petrositis is nothing but inflammation of petrous apex. So which cranial nerves will be involved? Obviously your 5th and 6th cranial nerves. And when your 5th and 6th cranial nerves are involved, will it cause pain in the area of distribution of 5th nerve? Yes. Will it cause 6th nerve palsy to cause diplopia? Yes. And why is this complication happening? Primarily because there is a middle ear disease, and this middle ear disease has led to petrositis, and this disease is a chronic suppurative otitis media presenting to you with a persistent ear discharge. So this condition where you have a persistent ear discharge, where you have got 6th nerve involvement and you have got a 5th nerve involvement, we call this triad as Gradinitis triad, and Gradinitis triad is a feature that you see in petrositis. So I'm sure all of you know the answer. The answer is A, otorrhea, ipsilateral abducent palsy and pain in the distribution of trigeminal nerve. Now where do you get conductive hearing loss, trigeminal nerve involvement and vagal nerve involvement, 5th nerve involvement, 10th nerve involvement and conductive hearing loss due to non-suppurative otitis media? This triad is called as your Trotter's triad. So this is your Trotter's triad. So sometimes you might get confused between Trotter's triad and Gradinitis triad. So I hope this is easy now for all of you. Okay, so Goodwill-Griesinger sign is seen in lateral sinus thrombophlebitis, where there is bluish discoloration of the mastoid due to thrombosis of the mastoid emissary veins. That sign is called as Griesinger sign, seen in lateral sinus thrombophlebitis. We have a question coming ahead, so I think that time you will be able to answer it. Great. Okay, so let's go to the next question. Which of the following is the distinguishing feature in a tuberculous otitis media? Again, this is a very common question. They can give you an image-based question with a very typical finding. What is that typical finding in tuberculous otitis media? Do you get a subtotal perforation? Do you get pruritus? Do you get the serosanguinous discharge? Or do you get multiple small tympanic membrane perforations? Now, I'm sure all of you know this and everyone is answering it absolutely right. So I won't waste your time. This is absolutely right. Multiple small perforations is the hallmark of tuberculous otitis media. So multiple perforations you will always see in tuberculous otitis media. The second very important feature that can be there in the image will be presence of granulation tissue. So what will you see? You will also see granulation tissue at a very typical location. Where will you see the granulation tissue? The granulation tissue is seen at the bony cartilaginous junction. So presence of granulation tissue at the bony cartilaginous junction is also another very important distinguishing feature of tubercular otitis media. Very good. Now let's go to the next question, which says which scan is the most useful scan in determining treatment endpoint in necrotizing otitis externa. So to help those people who still did not get the question here, I will help you. Necrotizing otitis externa is nothing but malignant otitis externa. So which radioisotope scan should be done to determine the endpoint in malignant otitis externa? Technetium 99 scan, gallium 67 scan, MRI with contrast or a CT scan. So I'm seeing that most of you are answering it very right. Absolutely correct. The answer is gallium 67 scan. Now why gallium 67? Why not technetium 99? A very quick explanation, because some of you have made a mistake in that. So I'll quickly explain to you about it. So when we talk about technetium 99 scan, technetium 99 is a radioisotope which is taken up by both osteoclast as well as osteoblast. So initially when there is an osteoclastic activity and bone resorption, So the scan will be positive. Because of osteoclastic activity, initial scan will be positive. Now when you give treatment, even after treatment, remodeling will continue, meaning the bony remodeling will continue, so osteoblasts will still be active. So even after treatment, the osteoblasts will still take up the scan, making the scan positive, meaning it will not tell us the end point of disease. Even after treatment, even after the infection has subsided, because of bony remodeling by the osteoblast, the scan will still be positive. But what about the other scan? The gallium-67 scan. Gallium is a radioisotope which is taken up only by neutrophils. And what are neutrophils? They are cells of acute inflammation. So initially the scan will be positive because of inflammation, but once you give treatment, neutrophils will disappear. And once the neutrophils will disappear, the scan will become negative. So this scan will help us to understand the treatment endpoint. So to understand treatment endpoint, the answer is gallium-67. But to understand initial investigation of choice, to understand early diagnosis or early involvement in malignant otitis externa, you are going to do a technetium-99 scan. Very good. So I am sure that all of you understood this. Okay. Now there is an image coming in front of you. Can you tell me what is striking at your head when you look at this image? Now this is something that you will have to know for sure. What is it that is striking to you when you're looking at this image? So please tell me, what is it? Here there is something that is very, very typical. I'll just point it out for you. What are you seeing here? What is the name given to this sign, and what condition do you get this sign positive? Yes, so here this sign is called as delta sign, or also called as empty delta sign. So this delta sign or empty delta sign is seen in a condition which is called as lateral sinus thrombosis. Yes, you can also get in other sinus thrombosis, Dr. Aman, but when we talk of ENT and CSOM and its complication, we will see it in lateral sinus thrombosis, which is also called as sigmoid sinus thrombosis. So in lateral sinus or sigmoid sinus thrombosis, we will get this sign which is called as the delta sign or empty delta sign. Now this is the investigation of choice for identifying lateral sinus thrombosis. Now is this a CT or is this an MRI? So this is an MRI with contrast, which will help us understand if there is a lateral sinus thrombosis. So this is the investigation of choice. Great. Now let us go to the next question. A 6-year-old child with failure to grow. So they have given you something very clearly. They have given you failure to grow, high arched palate, pinched nose, conductive hearing loss without any otorrhea, fever or pain. The treatment of this child will be myringotomy, grome, adenoidectomy, or all of the above. Now there is something that is pointing you to the diagnosis very, very easily. No pain, no fever, but there is hearing loss. And this child is also having failure to grow. There is high arching of the palate. What does all of these indicate? Very good. Some of you are telling C, some of you are telling D. So there is a mixed response. I'll tell you what is the right answer. So basically what we are talking in this MCQ is serous otitis media, which is also called as non-suppurative otitis media, which is also called as glue ear. Now why am I talking about glue ear, NSOM or SOM? Because no pain, no fever. So whenever there is pain and fever, you will think of acute suppurative otitis media. No pain, no fever, only hearing loss, you are going to think about non-suppurative otitis media. Now why did this NSOM happen in this child? Most common cause is adenoid hypertrophy. Have they given you any features of adenoid hypertrophy in this question? Yes, they have given you the features of failure to grow, high arching of palate, pinched nose. What does all that indicate? All these three indicates adenoid hypertrophy. So if there is adenoid hypertrophy, with serous otitis media, the first and foremost initial treatment will be wait and watch for 12 weeks, because the disease is known to resolve spontaneously. The SOM may resolve spontaneously. So wait and watch for 12 weeks. But if it is a chronic condition, because we are talking about failure to grow, we know it's not an acute, it's a chronic condition. Here the treatment will be treat the cause first. What is the cause? Adenoidectomy. And while you're doing adenoidectomy, you will also have to treat the hearing loss by doing a myringotomy and grome. So the treatment will be all of the above. So myringotomy, grome, and treat the cause, which is by doing an adenoidectomy. So all the three together will constitute the treatment of a child who is having adenoid hypertrophy along with serous otitis media. Okay. Now let's go to the next one. The tympanic membrane appearance in otitis media with effusion is it dull, lusterless, retracted with a restricted mobility, or is it pale grey amber colored? Is it thickened or dull or opalescent, or is there a fluid level or air bubbles, or all of the above? What is the appearance in otitis media with effusion? Yes, so I'm seeing many answers are coming in, but I see some of you are saying C, some of you are saying D, and some of you are saying E. So again, there is a mixed response. So here they are not asking you specific sign. Is there any word called a specific or diagnostic or definitive? No, they have not used the word. What is the word used? They are just asking tympanic membrane appearance. That's all. Now the tympanic membrane appearance in otitis media with effusion is variable. It can be dull, it can be lusterless, it can be thickened in some, thin in some, it can be blue colored in some, it can be grey colored, it can be amber colored. So it can be any type or any appearance can be seen, and it is a variable appearance. But the definitive sign for sure is presence of air bubbles and air fluid level. When they have not used explicitly the word definitive, the diagnostic sign, or the most definitive sign of SOM, then you are never going to mark only one option. Your answer will be all of the above. So here when they are saying what is the sign that you see, you can see any of them depending upon the amount of effusion in the middle ear, depending upon the negative pressure in the middle ear, depending upon how long the fluid has been in the middle ear, depending upon how thick or thin the fluid is in the middle ear. All that will determine the tympanic membrane appearance. So it is variable from one patient to another patient. So unless specified what is the diagnostic sign, don't mention as one sign. It will be all of the above signs that you see. But if they ask you most specific sign, then your answer will change to D. So look at the MCQ very carefully in your examination. Okay, let's go to the next question. Grome is used in glue ear, ASOM, both A and B, neither of these. Where do you use a grome? So this is also again a very common question in your examination. So can you tell me where do you use a grome? Yes. So if we are talking of grome, what is grome? Grome is basically a ventilating tube. This ventilating tube is communicating your external auditory canal with your middle ear. So we insert a tube that communicates the external auditory canal with the middle ear so that the air can go now from the canal into the middle ear. So in which condition will we do this grome? Yes, some of you are mentioning it as C, some of you are mentioning it as A. Those who have mentioned it as A, that is your right answer. It is used only in glue ear. Grome is used only in glue ear. Please remember, non-suppurative otitis media. But if the question would have been myringotomy is done in, then what would you answer? Then what would you answer? Yes, myringotomy can be indicated in both ASOM and SOM. Then your answer would be both A and B. So do not get into the the trap of examiner, whether purposely trying to find out whether you know it or not. So remember, Grome is only for glue ear, but myringotomy is done for both. So myringotomy both in ASOM and SOM, but Grome is done only in glue ear. There are specific indications when you will do myringotomy in ASOM and when you will do it in SOM. I am sure all of you know that, so I am not going to repeat that. Okay, the next question. The route of spread of infection to adjacent areas in CSOM is via all except round window, via bony invasion, via venous thrombosis, via lymphatic spread. So all of them can be routes of spread except, which is not a route of spread for middle ear infection to go to the adjacent sites in CSOM. Yes, Goodwill, the questions are tricky because in examination the examiner will want to trick you. This is where your MCQ solving skill or your ability to take a MCQ examination will come into play. So this is how you need to keep a practice of what you're doing, and that's how you will be able to clear your examination with ease. So keep practicing, you will know the tricks, you will be able to trick the examiner in your exam. Okay? Great. So all of you are answering it right, which is D. So typically whenever we have any middle ear infection, the middle ear infection can go to the inner ear either via the oval window or either via the round window. So they can be route of spread. It can go via the tegmen into the middle cranial fossa. This can be bony invasion. It can also go posteriorly to the mastoid and involve the sigmoid sinus in the mastoid. And when the infection goes to the sigmoid sinus, there can be venous thrombosis. So bony invasion superiorly through the tegmen, inner ear either through the round window or through the oval window, and posteriorly via the sigmoid sinus, it can cause venous thrombosis. But there is nothing called as lymphatic spread that can cause spread of infection. So lymphatic spread is not the cause of spread of infection to the adjacent area. So all the three are routes, whereas lymphatic spread is not the route of spread of infection. Okay, so let's go to the next question. Specific sign that you see in mastoiditis is, again this is a repeat MCQ which keep coming in examination and still people do mistakes. So what is the specific sign? They are not asking you which is seen in both, they are asking you specific sign. Lighthouse sign, reservoir sign, both or none. Good evening Mahinder. Yes, so I'm seeing again the answers to be differentiated. Some of you are saying A, some of you are saying B, and some of you are also saying C. And I think majority of you are falling into B, and I think that is the right answer. They're asking you which sign is seen only in mastoiditis. So when we talk about lighthouse sign can be seen in ASOM, acute suppurative otitis media, and mastoiditis. So what is lighthouse sign? Pulsatile otorrhea, the ear discharge which comes into the external auditory canal comes in a pulsatile form, and when you put your headlight and see, it keeps reflecting the light. That sign is called as lighthouse sign. It is seen in both ASOM and mastoiditis. But reservoir sign is a sign that you see only in mastoiditis. It is not seen in other conditions. So this is a feature that you see only in mastoiditis. So the most specific sign, your answer will be reservoir sign. Now what is reservoir sign? Now if there is pus in the mastoid, what will happen? The pus will come to the middle ear, and through the perforation the pus will come into the external auditory canal. Now if you mop the pus and if there is immediate reaccumulation of pus. So if there is immediate reaccumulation, it means that there is mastoiditis, and immediate reaccumulation indicates reservoir sign to be positive. So this sign is called as reservoir sign, and this is positive in a patient with mastoiditis only, not in ASOM. Okay? Yes, Goodwill, like a dam water, correct. Okay, so now let's go to the radiological feature that you see in acute mastoiditis. What feature is there on X-ray or a CT scan of a patient with mastoiditis? Will you see only the pneumatization pattern of the temporal bone? Will you see there is clouding of the mastoid hair cells? Will you see there is rarefaction of the petrous bone, or will you see thickening of the temporal bone? What feature is seen radiologically in a patient with mastoiditis? Now here I think there is no ambiguity, everyone is in the right place, everyone is answering very, very correctly. So the correct answer is B, which is clouding of the mastoid hair cells. So typically when there is pus in the mastoid, what will happen? It will appear hazy. So I will show you the image. Now if you see this image, this is the scan of a patient having mastoiditis. So this is the mastoid, and you see the hair cells are not black. Compare it with the opposite side. You see the hair cells are black, and when the hair cells are black, it means that they are air filled. But if they are hazy, grayish, it indicates mastoiditis. Typically when there is mastoiditis, the septa may be destroyed, and you can see that all the cells together coalesce to form a single cavity. So when they coalesce together, we call that mastoiditis as coalescent mastoiditis. So this type of mastoiditis is going to be your coalescent mastoiditis, and typically whenever there is an erosion, you will always look if there is any defect in the tegmen, any defect in the outer cortex. You will definitely look for bony involvement and erosion radiologically, and this you will appreciate on the CT scan of the temporal bone. Yes, so ice cream cone appearance, yes, here you can see this is the typical ice cream cone appearance. They are seen on the CT scan and they represent the ossicles. So when you are doing a surgery, you need to know whether the ossicles are present or not. So the ossicles, the head of malleus and body of incus on a CT scan look like a ice cream cone. So this ice cream cone appearance is seen of that of the ossicles, and if they are present, it indicates that the ossicles are intact. Okay. Yes, Dr. Saurabh, I will have to check with the team whether you can watch the ELITE plan or not. The team will reply to you in a while. Let's go to the next question. Schwartz operation is done in cholesteatoma, serous otitis media, otosclerosis, acute coalescent mastoiditis. Okay, so I'll take a question by Dr. P. In schwannoma also, yes, but that is in MRI, Dr. P. What we see ice cream cone appearance on MRI, not on CT, is vestibular schwannoma or acoustic neuroma. But what we're talking now here is on a CT scan. On CT scan of the middle ear, it represents the ossicles. But on a MRI of the cerebellopontine lesion near the internal auditory canal will be your vestibular schwannoma. So I hope you got the difference, Dr. P. Yes. So what is Schwartz operation? So Schwartz operation is nothing but cortical mastoidectomy. Cortical mastoidectomy is also called as canal wall up surgery. So when we say cortical mastoidectomy, it means nothing but canal wall up surgery. So where do you do this cortical mastoidectomy or Schwartz operation or canal wall up surgery? Yes, I see most of you have answered this right. It is acute coalescent mastoiditis, but some of you are answering it as C. Schwartz sign is seen in otosclerosis. I am not asking Schwartz sign, they are asking you Schwartz operation. So again, these tricks are there in the exam. Schwartz sign is seen in otosclerosis, which is flamingo pink appearance of the promontory seen through the tympanic membrane. But what we are discussing here is Schwartz operation, which is done for mastoiditis, acute coalescent mastoiditis. For cholesteatoma, we do something called as modified radical mastoidectomy, also called as canal wall down surgery. So MRM is nothing but canal wall down surgery, not up, but it is canal wall down. For serous otitis media, we have seen that you will do a myringotomy and a grome and treat the underlying cause. And for otosclerosis, you will either do a stapedectomy or a stepidotomy and place a prosthesis. So I'll quickly again show you a quick animated video of mastoidectomy so that you understand what is the meaning of Schwartz operation, cortical mastoidectomy or canal wall up surgery. Yes, Dr. P, I'm coming to your point where you want me to discuss about canal wall up and canal wall down. We will just discuss that. So just look at this video first and then we will discuss. So the same video where we discussed about the Mac-Evans triangle, then we will extend it forward. So first of all, again to revise, a post-oral incision is given. The skin and subcutaneous tissue is dissected. This is your mastoid bone. To enter the antrum, you will define the Mac-Evans triangle by supramastoid crest. Imaginary line drawn across the posterior wall of external auditory canal, and the third line will be your tangential line. You will drill in this triangle to reach the biggest air cell in the mastoid, and this biggest air cell in the mastoid is your mastoid antrum. Then you remove all the air cells. You will define the sigmoid sinus posteriorly. 1 second. So we will just see the video again because there is some rebooting of the video that's happening. So just give me 1 second to again continue from where I stopped. So we are seeing the boundaries of the Mac-Evans triangle, supramastoid crest, imaginary line across the posterior wall of external auditory canal, and the third line is your tangential line, and you start to drill the antrum and the rest of the mastoid air cells, and when you drill you know the certain limits. The tangential line represents the sigmoid sinus, so you will stop when you see a bluish bulge posteriorly representing the sigmoid sinus. Superiorly the tegmen antri, not the tegmen tympani, but it is the tegmen antri. So tegmen antri will define your superior limit, you won't go above that, and the imaginary line drawn across the posterior wall of external auditory canal will be your anterior limit, you won't go any further. Now when we do a complete mastoidectomy, we should be able to visualize the ossicles through the adytus in the middle ear. So we know adytus is the communication between antrum and the epitympanum. So you should be able to visualize the ossicles, you should be able to visualize the semicircular canals, and you must have removed all these air cells, then only we call it as a cortical mastoidectomy. But are we doing anything to this posterior canal wall? No, we are only excentrating all the mastoid air cells, keeping this posterior canal wall intact. Then we call it as intact canal wall mastoidectomy, also called as cortical mastoidectomy, also called as Schwartz operation. So Jitu, did you get the question why this is intact canal wall? Yes. Now the second part, what is canal wall down surgery? Now if I take away this bone, the posterior canal wall. So if I take away this bone, then we will call it as canal wall down surgery, and here we are making this entire mastoid middle ear and external auditory canal into one single cavity. So when we make all the three parts, the middle ear, the external auditory canal and mastoid into one single cavity, we call that as modified radical mastoidectomy or canal wall down surgery. Just give me a minute. This is not working. This is not working. Okay, so while we are setting up on the pen tab, let me just take you to the next question. A patient had persistent ear discharge and hearing loss. MRM was done and the patient returned back with persistent ear discharge and diplopia now. The cause is latent mastoiditis, diffuse serous labyrinthitis, purulent labyrinthitis or petrositis. So we've discussed this, so let me know your answers in the chat box. We have already discussed this so far, so let me know what's your answer in the chat box. See, they are telling you that there is a patient who's had persistent ear discharge and there is hearing loss. Now you did a surgery, but he came back to you with persistent ear discharge and diplopia. And what surgery did you do? MRM, modified radical mastoidectomy. So when do we do a modified radical mastoidectomy? We do it for patients who have either a cholesteatoma or an unsafe type of CSOM. So you will do in patients with cholesteatoma or unsafe type of CSOM. Correct? So if there is a patient who has cholesteatoma, unsafe type of CSOM, and if you have left back the disease, can it progress to a complication? Yes. So from the middle ear, can the disease go to petrous apex? Yes. And now can the patient have persistent ear discharge, fifth nerve involvement and sixth nerve involvement? Yes. So persistent ear discharge, diplopia because of sixth nerve involvement. What does it indicate? It indicates petrositis. So the answer is petrositis. Now why not labyrinthitis? See, in labyrinthitis, you will have vertigo. You will have sensory neural hearing loss. You can have tinnitus. But will you have sixth nerve involvement? No. Latent mastoiditis, you can have persistent ear discharge. You can have pain behind the ear. There can be swelling behind the ear. There can be, the pinna may be pushed forwards. All of that can be there in mastoiditis. But will the sixth nerve be involved to cause diplopia? No. The only option that's talking to you of diplopia with sixth nerve involvement is petrositis, which is why your answer will be D. Okay? So Ashutosh Ranjan, I think you're asking to me a question that we did previously on reservoir sign. So reservoir sign in CSF rhinorrhea is different from the reservoir sign that we see in mastoiditis. In mastoiditis, mopping the discharge with reaccumulation immediately is reservoir sign positive. But in CSF rhinorrhea, the patient is made to lie supine and on bending forward, there is CSF coming on off or watery nasal discharge coming off. That is the reservoir sign for CSF rhinorrhea. So basically your question will not have two similar they won't give you mastoiditis and CSF rhinorrhea as options. They will not give you that option at all because both of them context is different. So I hope you got the idea now. Okay? Fine. So let's go to the next question. A patient presents with ear discharge and underwent mastoidectomy. Post-surgery, he developed vertigo and sensory neural hearing loss. Now, we discussed this just a minute ago. The diagnosis is labyrinthitis, thrombophlebitis, temporal lobe abscess or mastoiditis. Yes, so Kanishka, my videos will be available from I think end of Feb and first week of March, and I'm actually still recording it. We are doing it right now. I'm also in the studio and recording it since last 2 days. So hopefully by the end of Feb and first week of March, you should be able to get all my videos, and most of it is actually done. So you will definitely get it. Don't worry about it. Yeah, so a patient presented to you with ear discharge and underwent mastoidectomy. Post-operatively, he developed vertigo and sensory neural hearing loss. This is for sure a diagnosis of labyrinthitis. So when we talk of labyrinthitis, we will have vertigo and we will have sensory neural hearing loss. What is labyrinthitis? Inflammation of the labyrinth is called as labyrinthitis. So labyrinth has your cochlea anteriorly, and the vestibule in the middle and the semicircular canals posteriorly. So when there is inflammation of labyrinth, can there be sensory neural hearing loss because of cochlear involvement? Yes. And can there be vertigo because of involvement of semicircular canals? Yes. So both these features can be seen in a patient with labyrinthitis. In thrombophlebitis, you will see other signs like bluish discoloration of the mastoid, papilloedema, raised intracranial pressure. In a temporal lobe abscess, you will have localizing features like hemiplegia, hemianopia, and motor palsy, sensory deficits, they can be present. And in mastoiditis, there will be only redness of the mastoid, pain in the area of mastoid, and there will be shiny skin over the mastoid, and other signs like lighthouse sign and reservoir sign. So this clinical picture with SNHL with vertigo is in very direct favor of labyrinthitis. Okay, which of the following is not related to complication of cholesteatoma? Toby-Ayers test, Krobek's test, Griesinger sign, Hitzelberger sign. Okay, so I am seeing the answers. Which of the following is not related to complication of cholesteatoma? Very good. So Toby-Ayers test, Krobek's test and Griesinger sign are all the signs that you see in which complication of CSOM. And I'm seeing most of you have answered it right. So all these three signs are seen in lateral sinus thrombosis or sigmoid sinus thrombosis. So this is seen in lateral sinus thrombosis or sigmoid sinus thrombosis. But Hitzelberger sign, what is Hitzelberger sign? It is loss of sensation or anesthesia in the area of distribution of your 7th nerve. We know 7th nerve and 8th nerve travel together in the internal acoustic meatus. So when we have a tumor coming from the vestibular nerve, it can compress the facial nerve. And this facial nerve has sensory supply in the region of concha. So in this region, you have the sensory supply of the facial nerve. So because of compression of the 7th nerve, there will be loss of sensation in the region of concha. So this loss of sensation in the region of concha, we call this sign as Hitzelberger sign. And Hitzelberger sign is not a complication of CSOM. It is seen in acoustic neuroma. So it is a sign that you see in acoustic neuroma. Okay, very good. Most of you have got this right. Okay, so lateral sinus thrombophlebitis is associated with all except Griesinger sign, Gradinitis triad, Krobek's test, Toby-Ayers test. So all are associated with lateral sinus thrombosis except which one? Yes, I am seeing the answers coming in. So Sharmila, please check your answer. I am saying except, which is not associated with lateral sinus thrombosis. Rest all of them are associated. One particular thing is not associated, and we have discussed that. We've seen that Gradinitis triad is a feature seen in which condition? In the first few questions we discussed this. This is a feature that you see in petrositis, not in lateral sinus thrombophlebitis. So it is associated with Griesinger sign where there is bluish discoloration and edema in the region of mastoid. Now what is Krobek's test and Toby-Ayers test? So Krobek's test and Toby-Ayers test are the tests which are clinically done to identify if there is lateral sinus thrombosis causing a raised intracranial pressure. So in Toby-Ayers test, what you do is first you will do a lumbar puncture. When you do a lumbar puncture, CSF tap will come out, right? Now once you measure the CSF pressure, automatically because of the thrombosis, the cranial circulation will not be able to drain into the jugular vein and there will be a raised intracranial pressure, and that will be shown in your LP. So you will put a manometer at your lumbar puncture and measure the CSF pressure as your baseline. That is your first step. So do LP, measure the CSF pressure. What is the second step? You will compress the IJV not on the diseased side, but on which side? On the normal side. Say right-sided there is a disease, you are expecting right-sided thrombosis. You will compress the IJV on the left side, not on the diseased side. Now when you compress the IJV on the normal side, there will be further increase in the intracranial pressure and your manometer will show you an increase in the CSF pressure. That sign that we see clinically is called as the Toby-Ayers test. Now the similar test with a similar principle but a non-invasive way is going to be your Krobek's test. What is Krobek's test? First you are going to do an ophthalmoscopic examination and you are going to record the size of the optic disc. Once you record the baseline size of the optic disc, you are going to compress the IJV again of the normal side, not of the diseased side. And now you will see there will be raise in the intracranial pressure. So what will happen? Will there be further enlargement in the size of the optic disc? Yes, so you will do a repeat ophthalmoscopy and you will check the size of the optic disc. You will see that there is an increase in the size of the optic disc, and this will suggest to you that there is a probability of sigmoid sinus thrombosis or lateral sinus thrombosis. So both of them are clinical tests for lateral sinus thrombosis, whereas Griesinger sign is nothing but bluish discoloration of the mastoid, and all of this are seen in lateral sinus thrombosis. Petrositis will present to you with Gradinitis triad and not with lateral sinus thrombosis. So I'm sure all of you got the answer. Let's go to the next question. Where is the electrode kept in a cochlear implant? So they're asking you, where is it placed? In the round window, in the oval window, through the scala vestibuli, or in the scala tympani? So Vikash Tiwari, basically whenever we do a Krobeck's test, we cannot assess the engorgement, the amount of engorgement. Yes, there will be engorgement of retinal veins, but can we define the amount? We cannot. But can we define the size of optic disc, which was 5 mm becomes 7 mm? So we can define that amount on optic disc, which is why we take that as our reference point. But yes, don't we see engorgement? We see engorgement, but we cannot exactly tell the number, or there is no objective definition to tell how much engorgement. Okay. Yes, so very good. Most of you have answered it right, while some of you are answering it as A. They are asking you kept, they are not asking you inserted through. So when the question is where this cochlear implant is inserted through the round window into the scala tympani. So if we take the cochlea, it has got two compartments. It has got a scala vestibuli above, a scala media in the middle, and scala tympani below. So when we insert an implant into the cochlea, we will pass it through this window. What window covers the scala tympani? It is the round window. So if the question was where is the electrode inserted, or through which membrane it is inserted, then the answer would have been round window. But they're asking you, where is it kept? The electrode is kept in the scala tympani of the cochlea. So if you have to check your question, you need to check, are they asking you inserted through? Then your answer will be round window. Otherwise, your answer is going to be scala tympani. So very good. I'm seeing again most of you got it right. So if you see, this is how the cochlear implant surgery is done. So you will basically do a mastoidectomy and through the facial recess approach. What is facial recess? I will come again. We have a MCQ next line ahead. So we will do it there. But through the facial recess approach, you will go through the round window and insert the electrode into the scala tympani of the cochlea. So this implant is called as a cochlear implant. Now let's go to the next question. Micro Wick and micro catheter are sustained release devices that are used in drooling of saliva, Frey syndrome, control of epistaxis, or drug delivery across the round window. Now again, this is something that you can have in your examinations. So Hussein, I think explained to you about the round window and the scala tympani part. Oval window and scala vestibuli have got no role in a cochlear implant. We don't touch them at all. Yes, so if I see most of you are getting it right, the answer is in round window membrane, option D. So micro Wick and micro catheter are sustained delivery devices that we use in patients with Meniere's disease. So in patients with Meniere's disease, most often these patients require steroids in the part of the treatment. Now systemic steroids are associated with lot of adverse effects. So you want to give a topical steroid. Now topically, how will you reach the inner ear? To reach the inner ear, you have to go through one of the windows. Which window would you prefer? Oval window, which is covered with stapes, or round window which has nothing above it? So you will definitely choose the round window. And now through the round window, you can put a wick or you can put a catheter and deliver the drug into the cochlea? Yes. So these are drug delivery devices that are used across the round window in patients with Meniere's disease. So this is how the micro wick or a micro catheter would look like. So this will be placed across the round window because oval window has what? Stapes about it. Now over this wick you will fill the ear canal with the steroid drops. The steroid drops will get absorbed through the wick and go to the inner ear, and this is how you will be able to achieve a good concentration of steroid into your inner ear. Okay, the next question which I was telling you about the posterior tympanotomy or the facial recess. So while doing a posterior tympanotomy through the facial recess, there are chances of injury to all of the following except, so what will not get injured when you're doing a surgery through your facial recess? That's your question. Facial nerve horizontal part, chorda tympani nerve, dislodgement of short process of incus from fossa incudis, vertical descending part of the facial nerve. So all of them can get involved except one structure. So what is not involved? Please tell me that answer. Yes, I can see some of you got it right while some of you are saying D. So let me first explain you the answer, then you come back and solve the question for yourself. So let us understand this mastoid cavity. When we do a surgery or a mastoidectomy, you can say this is a mastoid cavity. Now the structure that you see here, this is going to be your facial nerve. Which part of the facial nerve is in the mastoid? The vertical part. It gives a branch. This is your chorda tympani nerve. Okay, and here you can see the incus above. This is your fossa incudis. Now if I remove the bone in this triangle, what will happen? All this bone will be removed, and when I remove the bone in this triangle, will I be able to see the middle ear and the round window? Yes. So this approach, we are going to the middle ear from the canal. No. Are we going from the mastoid posteriorly? Yes. So tympano means middle ear, tomy means opening. Posteriorly we are going, so it is posterior tympanotomy, and the recess is called as facial recess because it is in the branch of the facial nerve and the chorda tympani nerve. So when you are doing a surgery here, can you traumatize the vertical part of the facial nerve? Of course, yes, because you're very close to it. Chorda tympani nerve, yes. And can you dislodge the incus while you're doing the surgery? Yes. But can the horizontal part of the facial nerve be involved? No, because that's in the middle ear. That's somewhere here. It's not in the mastoid. So horizontal part will not be involved. So now go back to the question and now answer. Now I'm sure most of you know this absolutely right. So the answer is facial nerve horizontal part. Rest of them can get injured during the surgery, but horizontal part of facial nerve is less likely or most like not, it's most often not going to be involved while doing the surgery. Very good. Now let's go to the next easy peasy question after giving you some tricky questions. Time to rest your brain and just answer it spontaneously. Endolymph in the ear is a filtrate of the blood serum. It is secreted by the stria vascularis. It is secreted by the basilar membrane. It is secreted by the hair cells. Now I think this is something that everyone will know by heart. Very easily they know. And I'm sure I don't need to explain that at all. And I'm seeing everyone is answering it absolutely right. The answer is stria vascularis. Very, very good. So where is stria vascularis? When we take cochlea, we have three compartments: scala vestibuli, scala media, and scala tympani. In the scala media, we have got a vascular membrane. This vascular membrane is going to be your stria vascularis. This stria vascularis is responsible for both production of endolymph and also reabsorption of endolymph. So production and reabsorption of your endolymph is done by your stria vascularis. So this is your correct answer. It is produced and reabsorbed by the stria vascularis. Okay. So next, again very simple repeat question which comes in your examination, but we tend to often forget this topic. Vertical crest of bone in the internal acoustic meatus is Bill's bar, ponticulus, cog or falciform crest? Again, this is a very easy question. If you've read internal auditory meatus anatomy, you should be able to answer it in a jiffy. Very good. All of you are absolutely right. So if we take a cross section of the internal auditory canal, we have a vertical crest of bone. This vertical crest of bone is called as Bill's bar. And then we have a horizontal crest of bone as well. So this horizontal crest of bone, we call it as falciform crest. So this is your falciform crest. This will divide your internal auditory canal into 4 quadrants. In the antero-superior part, you have got the 7th nerve. Antero-inferior part, you have the cochlear nerve. And I'm sure everybody knows this mnemonic, 7 up, coke down. So cochlear nerve is down and 7th nerve is up. And then in the posterior quadrant, you have superior vestibular nerve and you have the inferior vestibular nerve. So vertical crest of bone is going to be your Bill's bar. Now what is ponticulus? Ponticulus is an extension from the promontory to the pyramid. So if we take the middle ear, in the middle ear you have a projection on the posterior wall called as the pyramid. And you have promontory which is formed by the basal turn of cochlea. So you have an extension from the promontory to the pyramid. This is called as your ponticulus. An extension of promontory to the round window, we call it as subiculum. And the space that is present in between the two, we call it as sinus tympani. Okay? So let's go and see the anatomy again here. So you can see ponticulus is from pyramid to the promontory, and from promontory to the round window you have subiculum, and here you have got the sinus tympani. So you can see ponticulus is from promontory to the pyramid, subiculum is from the promontory to the round window, and the space between them is called as sinus tympani. Okay? Now cog is nothing but the vertical bone that you have in the attic or epitympanum. So in the attic or epitympanum, you have a vertical crest of bone that is called as your cog. Okay, now let's go to the next MCQ. Having understood those anatomical terms, let's do a physiology of hearing question. Rinne's test is negative in sensory neural deafness, acoustic neuroma, tympanosclerosis, Meniere's disease. Where do you get Rinne's test negative? Now this is something that is a very easy question. Where do you get negative Rinne? Very good. I am seeing many of you are answering it right. Whenever we say a test like Rinne's test as positive, it means patient is either normal or having sensory neural hearing loss. If a patient is having Rinne negative, it means the patient is having conductive hearing loss. So amongst the options given to you, which one is a conductive pathology? The only conductive pathology that you have is tympanosclerosis. Tympano means middle ear, sclerosis means bony deposition. So if you have a bony deposition in the middle ear, we call it as tympanosclerosis. So any pathology in your external ear and your middle ear will result in conductive hearing loss, and hence the Rinne will be negative. SN loss, acoustic neuroma, which is a tumor coming from your vestibulocochlear nerve compressing the cochlear nerve, will result in SN loss, and Meniere's disease also will cause sensory neural hearing loss. So in all the other 3 conditions, your Rinne's test will be positive. Only in tympanosclerosis, which is a middle ear pathology, Rinne's will be negative. Okay, let's go to the next question. Again with the same concept that we discussed, Rinne's test positive is seen in CSOM, normal individuals, otomycosis, wax in the ear. Now this is something that is very simple, but students do get confused in the exam. Like when we say patient is HIV positive, HBsAg positive, COVID positive, we think the patient is having a disease. But when there is Rinne positive, it is often seen in which people? Very good, everyone's answering it right, in normal individuals. So Rinne positive is seen in normal individuals or SNHL. So don't forget, Rinne positive can be seen in normal people. Rest three options, CSOM, otomycosis and wax, will result in conductive hearing loss with a negative Rinne. So in all the other three options, Rinne is negative. Normal individual Rinne will be positive. Okay, let's do a tricky question on tuning forks now. A middle-aged woman presented to you with a right-sided hearing loss. So there is a right-sided hearing loss. Rinne's test shows positive on the left side, negative on the right side. So when you given a Rinne's test, always do a box like this, right and left. What are they telling? Positive test on the left side, negative test on the right side, and Weber is going towards the right. What is the diagnosis? Right conductive hearing loss, right sensory neural hearing loss which is severe, left-sided sensory neural deafness, left-sided conductive deafness. Now this is a little bit tricky question. Let me see how many of you will get the answer. Very good, Dhananjay, Shiv, Tanushri, Pinky, Vishwa, very good. I'm seeing that you're able to answer it right. This is a pathology where you have got unilateral severe to profound sensory neural hearing loss. So whenever you have a unilateral severe to profound sensory neural hearing loss, you will have a false negative Rinne. So if you have a unilateral severe to profound sensory neural hearing loss, you will get a false negative Rinne. Okay, so you will get a false negative Rinne. Why? Now normally when you see, what happens if there is a patient, say, having a right-sided severe to profound sensory neural hearing loss. This is severe to profound, meaning there is more than 70 to 90 decibel loss. So if you keep a tuning fork in the air conduction route, will the patient hear the sound? No. Now you put the tuning fork on the bone. Will the patient hear the sound? No, not from that cochlea. But will the patient hear the sound through the opposite cochlea and going to the brain? Yes. So here the patient's BC is greater than AC, and when BC is greater than AC, we call it as Rinne negative. Now is this truly negative? No, it is falsely negative because the conduction is not happening from the same cochlea, it is happening through the opposite cochlea. So false negative Rinne will be seen in unilateral severe to profound SN loss. So here when we say severe to profound SN loss, Rinne will be negative on the right side and Weber will go towards the opposite side. So Weber is going to the left is mentioned in the question. So when the Weber is going to the left side, you must think about severe to profound sensory neural hearing loss, because the hearing loss is on the right side, opposite side is sensory neural, same side will be conductive. So your answer will be B, right-sided severe to profound sensory neural deafness. Okay, so let's go towards the next question. High frequency audiometry is used in otosclerosis, ototoxicity, non-organic hearing loss, Meniere's disease. Yes, Faryal Iqbal, we can have a session only on tuning fork test. It's a very detailed chapter. We'll have to go right from the basics to get the tuning fork test right. But today, since we are doing a lot of MCQs discussion, we will take this up topic in the next classes or upcoming YouTube sessions and help you understand on how to do the tuning fork test. And we can do some combinations as well. So when we talk of high frequency audiometry, what does it mean? Normally, we are going to test somewhere from 125 Hz to 8000 Hz because this is our speech frequency. But if we test beyond, like say 16,000 Hertz, 20,000 Hertz, so we call it as high frequency audiometry. And high frequency audiometry is done typically for two conditions. One is noise induced hearing loss, the other one is ototoxicity. So in both of them, what you will see is initially the higher frequency will get affected, later the normal frequencies will get affected. So in the early phase of the disease, you want to identify is there a loss or not. So to identify the presence or absence of loss, you will do a high frequency audiometry in these two conditions, which is noise induced hearing loss and ototoxicity. So the answer is ototoxicity. Very good. Okay, so let's go to the next question. Again, this is a repeat MCQ in the previous examination. Post head injury, a patient had conductive deafness and on examination tympanic membrane was normal, but there was an increased compliance on impedance. So on impedance, I'll give you AD type of graph was seen. I'm giving you the takeaway point. Now tell me the answer. What is the diagnosis? Is it distortion of the ossicular chain, hemotympanum, tympanosclerosis or otosclerosis? Now following injury, tympanic membrane is normal, but there is increased compliance. So what should you think of? Obviously, because of trauma, there is dislocation of ossicles and everyone have got it right. So I won't discuss any further. You're right, distortion of ossicular chain is the answer. Okay, let's go to the next one. In facial nerve palsy of the right side, stapedial reflex is absent on which side? Right side, left side, both sides or not absent at all? So what should your answer be? Very good. So I'm seeing that some of you are getting it right. So right-sided stapedial reflex will be absent on if there is facial nerve palsy only on the right side, on left side or both sides. So for that you should know in stapedial reflex the afferent is via your 8th nerve and your efferent is via your 7th nerve. So if the afferent is via 8th nerve, you will have, if there is a 8th nerve pathology, you will have bilateral loss of stapedial reflex. But if efferent is your 7th nerve, you will have unilateral loss of stapedial reflex. And when we talk of unilateral loss, we talk of only the ipsilateral side. So which is why you will have only right-sided involvement. So right-sided facial palsy will cause loss of stapedial reflex only on the right side, not on the left side. To explain you further, we will have the stapedial reflex pathway. So you see that loud sound goes from the middle ear to the inner ear, from the inner ear via the 8th nerve to the cochlear nucleus. From there it goes to the superior olivary complex to ipsilateral and contralateral side, and from there via the facial nerve it will cause contraction of the stapedius muscle. So any pathology in the 8th nerve, the impulses won't get conducted further, so there will be bilateral loss. But any pathology in the 7th nerve, there will be only ipsilateral loss. Got it? I hope you got it. Kapil and Divya, you both were asking to me, so I hope you got the answer for this question. Okay. So next question, initial screening test for newborns with hearing loss is ABR, otoacoustic emissions, free field audiometry, visual reinforcement audiometry. Again, this is a very common question. Again, a little confusion to understand which is a screening test and which is a confirmatory test. And I'm seeing all of you are getting correctly. Yes. So when we talk about screening test for hearing loss in infants and children, it is always otoacoustic emission. So screening is otoacoustic emission. Confirmatory is your auditory brainstem response or BERA. So BERA is for confirmation. Screening is always by your otoacoustic emission, and I see all of you are answering it right, so I will discuss no further on this. Otoacoustic emissions arise from inner hair cells, outer hair cells, both inner and outer hair cells, macula. So from where do you get otoacoustic emissions? This is again a very easy O for O. I'll give you a hint. Now at least you should be able to answer. Yes. So otoacoustic emissions come from the outer hair cells because outer hair cells are efferent. They are nothing but your type 2 hair cells. Now, if you see the alphabet I or inner hair cells, does it resemble Roman digit 1? So, they are single hair cells, they are inner hair cells, and they are, what is the first alphabet in your English? A, right? So, they are afferent hair cells. So, this is how you can remember. A is the first digit. So, they are inner hair cells, single hair cells, afferent, whereas efferent is your outer hair cells. So, otoacoustic emission comes from the efferent or the outer or the type 2 hair cells. Okay, now identify this condition and tell me what are you seeing here. So, Divya, otoacoustic emission is by the outer hair cells where we have a small probe in the external auditory canal and there is a handheld machine like your mobile phone. It will just tell you OA is present or absent. If OA is present, nothing to do, the child is good to go. But if OA is absent, then you need to refer the child for further examination. On BERA, you're recording all the waves that we see on the auditory pathway, right from the cochlea till the brainstem. So, we will be able to understand the pathology or transmission of the sound from the cochlea to the cochlear nerve through the cochlear nucleus olivary complex and be able to point out where is the pathology. So, this is in brief the difference of OA and BERA. Okay. So, this is an image showing to you keratosis obturans. So, here there is a ciliary motility defect and as a result there is accumulation of mass of keratin in your external auditory canal, and because of mass of keratin is accumulating, skin is getting accumulated one layer over another layer, we call this as onion skin lamellar arrangement, meaning first layer of epithelium, then second layer, then third layer, like this it is getting arranged one over the other. This arrangement we call it as onion skin lamellar arrangement. Will you see widening or erosion? This is not an erosive disease. You will see widening of the external auditory canal, and because of that there can be involvement of the seventh nerve. Now, typically this has to be removed with sedation or with general anesthesia because it's quite a painful condition. Under local anesthesia it can be a little difficult to remove, so you will have to give a little bit of sedation and remove it. So, the treatment is removal of the keratotic debris. Yes. What is the incision used in endomeatal approach of the ear? So, please remember they are asking you endomeatal. They are not asking you end oral or post oral. What is the name given to endomeatal approach? Is it called as Lempert's 1, Lempert's 2, Rosen's or Wild's incision? Yes, Tanushri, keratosis is associated with bronchiectasis and sinusitis, which are other ciliary motility disorders. Correct? Yes. So, when we say endomeatal approach, we are talking about an incision. Very, very good, Neelam, Divya, Sarika. It is your Rosen's incision. So, Rosen's incision is your endomeatal incision. Lempert's 1 and Lempert's 2 are end oral incisions. So, they are your end oral incisions. And you have the Wild's incision. Sir William Wild's is going to be your post-oral incision. So, post-oral is going to be Sir William Wild's incision. Okay, so I am sure most of you got it right. So, I will just explain the incision. So, post-oral incision begins from the pinna behind. We have seen that incision in my mastoidectomy video. So, we will skip that for now. What is end oral incision? So, here we will start the incision from incisura terminalis and go into the external auditory canal, and we will take this incision at the bony cartilaginous junction from 12 o'clock position to 6 o'clock position. So, you will extend this incision up to the bony cartilaginous junction from 12 o'clock to 6 o'clock. So, if you have only this part of the incision 12 o'clock to 6 o'clock at bony cartilaginous junction, it is going to be your Lempert's 1. But if you extend this incision up to the level of incisura terminalis, then you will call it as Lempert's 2. So, the same incision extending up to incisura terminalis, it is Lempert's 2. Okay. What is endomeatal? Endomeatal or permeatal incision is about 6 to 8 mm away from the tympanic membrane, you are going to make an incision again from 12 o'clock to 6 o'clock position. You will make an incision 6 to 8 mm away only in the bony part of the canal, not at the bony cartilaginous junction. You are going to make only in the bony part of the canal 6 to 8 mm away from the annulus from 12 o'clock to 6 o'clock. That is going to be your endomeatal incision. And post-oral is behind the pinna, about 1 centimeters behind the retroauricular groove, from the highest point of the helix up to the tip of the mastoid. We call it as Sir William Wilde's post-oral incision. So the last question for the day, just identify this device and we will stop our otology class for today. Tomorrow I'll come up with more questions on rhinology, larynx and pharynx. So identify this device. Is this a piston that is used in stapedectomy? Is this a grome? Is this a TORP, which is total ossicular replacement prosthesis, or none of the above? What do you think is the answer? See, here you can see that this is a prosthesis. Now the piston that you use in stapedectomy will typically look like your question mark. So remember that. Why will it look like a question mark? Because this has to anchor to an ossicle, which is your incus. So you have to hang the piston to the incus. So that's why it looks like a question mark. So it is not looking like question mark. So it is not the piston that we use in stapedectomy. Now grome is like a tube, like a plastic tube. Is it looking like a plastic tube? No. Now what is this then? These are partial and total ossicular replacement prosthesis. So if you don't have ossicles, so between the tympanic membrane and the footplate of the stapes, if you use a prosthesis, we call it as TORP, meaning it is replacing all the ossicles. Totally it is replacing the ossicles. So total ossicular replacement prosthesis. But if you say you have malleus and you have some part of the incus and now you use a prosthesis, this is used only partially to replace the ossicle. So this is going to be partial ossicular replacement prosthesis. So the prosthesis that you see here is going to be TORP and PORP. Okay. So with this, we finish our first session of otology, and I am more than happy to see all of you answering it absolutely right. Your preparation is definitely very, very complete. Only a few areas you got a little tricked, but that's okay. It's always better to practice now, do your mistakes now and not in the examination. Now we are very, very close to the examination. It's time that you pull up your socks, do what you can to the maximum capacity. Just remember that this is the time where you need to put your best foot forward. Don't think of whatever has happened behind or whatever will happen ahead. I know it's common tendency for every one of us to think about the future, to think of what we did and where we stand today. But I think the only best case scenario would be to just understand the situation where you are in and do what you can do today. And whenever you feel like thinking about all those things, just distract your mind away, either by listening to music or do something that will distract such thoughts away from you, so that you can still be aligned on the day that you are. So keep practicing. Even if you haven't studied some topics or certain chapters, it's still okay. Whatever you have done so far, just stick to it. Just keep reading. Don't look at advices that are given to you from all around and everywhere. Remember, every person is unique. Your preparation is different. Everyone else's preparation is different. Whatever suits the best to you, you know. Nobody else knows. So just stick to what your gut is saying, what you feel like, and just go ahead doing that. Don't think that my friend is doing this, or that teacher gave me this advice, this teacher gave me this advice. Everyone is going to give you advice for your betterment. I agree. But you need to know what you have to take and what you have to leave based upon you as a person. So I will just say that, and I will wish you all good luck, and I will see you again tomorrow with a next session with rhinology and pharynx and larynx MCQs. Okay, so fine everyone, I will take your leave now. Thank you for all the appreciation in the chat box. I will see you later. Take care and bye-bye.